So I'm going to talk a little more now about addiction. I'll end with a little bit about medication-assisted treatment, and then Melissa's going to talk more about medication-assisted treatment. This is data that comes from a survey done by the federal government every year. They do 70,000 face-to-face surveys. It's the SAMHSA National Survey on Drug Use and Health, and we get pretty good data from it on drug use trends. You don't get good data on addiction trends, but drug use trends are pretty good. And what we see from this survey, you see that there was a very sharp increase in non-medical use or abuse of prescription opioids that began in the late 90s, and ever since it's been coming down. It's been coming down since 2002. And what you're really looking at are the people who reported on this survey that they took a painkiller non-medically. Much of this are kids experimenting with painkillers. And of course, this is a really nice trend, because if kids are experimenting with painkillers less frequently, then they might be less likely to become addicted. And if you look at the way the federal government has attempted to address our opioid crisis from the beginning, the focus really was on non-medical use. ONDCP, SAMHSA, FDA. When you heard federal agencies speaking about the problem, you often heard them say, we've got to stop the non-medical use, the drug abuse, but let's not interfere at all with the way doctors are prescribing for pain. And so the idea was, let's keep the kids from getting into grandma's medicine chest. Now, you can see we've had an improvement since 2002 in non-medical use or abuse of painkillers, yet as you all know, our opioid crisis has been getting worse. So why, if non-medical use has been going down, is the opioid crisis getting worse? And here, this is data showing you overdose deaths in counties across the country. And it's starting here, this is 2002, and I just started at 2002 because that's this point here. In 2002, we had a serious problem with overdose deaths. What you would want to see is the whole country looking this darker blue color, and you see this light color in many regions of the country in 2002, and the red areas have the highest rate of overdose death. And you could see that from 2002 to 2014, it got much worse. So what's going on? Why is the problem getting worse if there's been a decrease in abuse of painkillers? And it's because we really don't have an epidemic of abuse of painkillers. This data on the left is showing, it's from the SAMHSA survey, and it's showing you the age groupings where abuse or non-medical use, recreational use of painkillers is most common. And you could see that the age group where taking a painkiller non-medically is most common are the younger groups, 15 to 24. But if you look at the age groupings where overdose deaths are most common, you see that the age group with the highest rate of overdose death is 45 to 54, this group here. So something very different is going on, and I would argue that really what's driven the increase in overdose deaths has been, and what's driven our epidemic, it's not kids getting into grandma's medicine chest that's the problem. It's, as you've been hearing today, the medical community overprescribing opioids and many people getting addicted to opioids. One point I also want to make on this slide is I don't really believe this. This would show you that you've got very low rates of overdose death in people 65 and up. And I'll show you in a moment why I don't believe it, the data that would argue against this being real. What is real is that older people we're counting less overdose deaths. That's what you're seeing. But I don't think that older folks are less likely to die of an overdose. If an older person doesn't wake up in the morning, let's say because they took too many painkillers, grandma doesn't wake up because she took too much OxyContin. What generally happens, and it's different in different municipalities, but what will generally happen is that 911 is called. EMS or police may come to the scene, and they look to see if there's anything suspicious. And if they're coming to the scene of an overdose and there's a young person there who's died and there's nothing, why would a young person be dead? Or if they see drug paraphernalia at the scene, that's suspicious. That body is going to go to the medical examiner. Toxicology is going to be performed. We're going to count that death. If an older person doesn't wake up in the morning and nothing looks suspicious, and it's an older person with multiple medical problems, at that point what typically happens is the patient's doctor is called and asked to come to the home to sign a death certificate. And even in a case where everybody may have known that grandma had a problem with her pain pills, the family knew it, the doctor knew it, maybe the doctor was the prescriber. Nobody wants grandma to have died of a drug overdose. Nobody wants grandma to go to the ME. They want grandma's body to go to the funeral parlor. And so, and at my last position, I was at a hospital where we had a state licensed, because we were state licensed, we were required every time we had a death of one of our patients, even in our outpatient, even a death in a patient with metastatic cancer, we were required to investigate the death and do a little summary. And so we had to investigate every death, and we came across multiple cases where when we investigated, we believed it was an overdose. A patient in our mental health clinic who was getting Xanax from the psychiatrist or Klonopin and getting opioids from a pain doc, and there were even recorded episodes of non-fatal overdose in the chart. And so we concluded it was a probable overdose death, yet the death certificate said death from natural causes, COPD, cardiac. So I think we're undercounting these deaths, and I'll show you another reason why I believe that in a minute. So I would argue that our opioid crisis is an epidemic of opioid addiction, and I think we roughly have three different cohorts. We've got a cohort of younger Americans who are mostly white, and that's the group that Sam was just talking about that has been switching over to heroin in large numbers. We have another group, also mostly white, 40 and up, that have developed opioid addiction through exposure to pain medicines. That group is less likely to wind up switching to heroin. They are more easily able to obtain pills from doctors. And then we have this third group of individuals who are really survivors of the heroin epidemic that we had in the 60s and 70s, and sort of this aging, shrinking cohort. From this group, many died of overdoses or died of AIDS when HIV hit, because many were injection drug users. As Sam mentioned, in the 70s, if you were opioid addicted, you were injecting heroin because it was very difficult the heroin was not of good enough quality to really snort or smoke as well. So people were injectors. This group is different in that they developed their opioid addiction through heroin use, and typically through injection use. And this group started very young. So even for these folks, the younger people who are getting opioid addicted now through either recreational use of pain medicine or through medical use, usually their use is beginning in their late teens and early 20s. This group, certainly in the 70s, they were very young. They were 16, 17, and they started generally with a needle in their arm. So a different population. In fact, for the younger folks today, and I don't know if I mentioned this, I work at an addiction treatment agency. We're in different states, and when we formed 40, 50 years ago during this epidemic, and the young people we were treating, they were folks from inner city communities mostly, and they were heroin injectors, and they often had a history of juvenile delinquency and being in gangs even before they began their heroin, became addicted to heroin. And the treatment model was almost like a boot camp-like model that was going to treat the socially deviant behavior. The drug use was seen as secondary to the socially deviant behavior. The young people we're treating now are almost entirely high school grads. In many cases, they have some college, or they're even college grads. Many have a history of some type of stable employment. It's a very different population from the population that we were started off treating. So this, I showed this slide earlier. This is that younger white group that I mentioned. This is that middle-aged group that I think is playing a role in the changing life expectancy in the United States. The older group, I told you I didn't really believe that we've got so few opioid overdoses in people 65 and up. This is evidence to support what I'm saying. This is data, it comes from it's hospital claims data. And in this study, they used the term opioid overuse using the diagnostic codes on the claims data. And these were patients admitted to hospitals for non-fatal overdose or coming into a hospital seeking detox or treatment for opioid addiction. And so they termed it opioid overuse. And this is 1993, before our opioid addiction epidemic, and you see the different age groupings. This is probably, I'm guessing, it's probably that cohort that got addicted to heroin, coming into hospitals for detoxes and with non-fatal overdoses. And that age group, that's kind of where they would have been at the time. Now, I want you to look at this group. So people who were 65 to 84 in 1993, that group would be 20 years later in this darker color. And you see this very sharp increase in people who are over 85 showing up in hospitals for overdoses or with what was termed opioid overuse. So we don't pick them up on the overdose death data from medical examiner data, but we are picking them up from hospital claims data. So we do have a very serious problem in older folks with opioids. I showed a slide that looked like this earlier. It was the data for people who came into drug treatment saying that their primary drug was prescription opioid. This is the heroin. And this is actually at Phoenix House. This is what our programs look like right now. And so you see this very sharp, this very large group of young white people who are coming in addicted to heroin. And then here you see that older cohort of African Americans here in red, Latinos here, and Puerto Ricans here in green. And if you're looking at this and thinking, well, maybe the non-white groups are low because they're underrepresented, maybe they're less likely to get addiction treatment. That isn't the case. This is data coming from state licensed drug and alcohol treatment programs where you are more likely to see patients from lower income populations. This is the state system. And if I put up the slide that said smoked cocaine, the crack cocaine slide, you would see a red line significantly bigger than the blue line. So this is real. And I think this is really showing you the different groups. And if you visit a New York City methadone maintenance program, this is what you'll see. Or the Phoenix House programs that we have. You'll see the smaller group of older men from inner city communities and this very large group of young white people. So take a look at this black line. And you saw this before. You've seen it a couple times today. That's overdose deaths. And from 1999 to 2014, that black line represents more than 250,000 deaths. And as you know, probably an undercount. So an enormous death toll. The last time demographers saw anything like this, or people who study life expectancy, was during the AIDS epidemic, where you had a very large number of people dying who you wouldn't have predicted that they were dying. And yeah, you can see here that opioid overdose deaths were previously rare, now they've become one of the leading causes of death in the United States. So how do we make this go down? And it's not even getting better, it's getting worse. How do we tip that? And I showed the HIV death trend previously, and you saw that after antiretroviral therapies were introduced, there was this sharp decline in deaths from AIDS because HIV became a chronic illness. So I think the best shot we've got at getting that black line to come down, well, obviously we have to prevent new cases of opioid addiction, but for the people who are addicted, we have to see that they're accessing effective treatment. And Phoenix House is mainly been in the business of residential treatment, and up until recently, our programs had been abstinence-based. We saw methadone maintenance as the bad guys, and we've changed. I think that we've got to see that patients are accessing effective treatment. Sending people to rehab is not going to cure their addiction. Detoxing people is certainly not going to cure their addiction. And when when you do detox someone and send them home, they're very frequently going to pick up again pretty quickly. And not only haven't we really helped them, but in some cases you set them up for an overdose death, because one of the biggest risk factors for an overdose is to be status post, rehab, detox, jail, when people's tolerance has come down. So why do I believe that better access to buprenorphine would help us turn the corner on deaths? It's because it's happened before. It happened in France. So in France, buprenorphine gets released in the mid-90s. And it was released in France, and there was very little methadone maintenance, and France has had a serious problem with heroin. And so buprenorphine is released. It's just Subutex, the easier to inject version. And it's released without any training requirements. So how many people here took the buprenorphine training yesterday? So, no training, it just gets released. And no caps on the number of patients that doctors in France can treat. And what happens is the medical community starts prescribing it. The prescribing just takes off. And quite a bit of the buprenorphine winds up on the black market. And you can't, it's hard to get, you don't really get a high from buprenorphine if you're taking it the way you're supposed to. You can definitely get a high from buprenorphine if you haven't used an opioid for a while and you take it, or if you inject it. And it was easier to inject version, so a lot of it is also being injected. Despite the black market diversion, the overdose death rate in France dropped 79% in 6 years. So from a public health standpoint, this was an enormous success. And Melissa will talk a little more about the pharmacology of buprenorphine, but as a partial agonist, overdose deaths involving buprenorphine are pretty rare. There's a ceiling on its effects, including respiratory depression. So how are we doing with expanding access to buprenorphine treatment? Well, these lines are referring to age groupings, and this is 2003 to 2013. And these are people addicted to heroin who should be getting referred to methadone or buprenorphine. And the fact that the lines are flat is telling us that we are totally failing in seeing that people who are opioid addicted are accessing effective treatment. Why are we failing? There are many barriers. There are the ideological barriers, which are a problem, and I've certainly seen it at Phoenix House, where we had people running some of our treatment programs who were in recovery, who recovered using a therapeutic community model or some other abstinence-based approach, and felt that that's really the only true way to be in recovery. I will say that in some of our programs, it was easier than you might imagine to to tackle that ideology, because when you've got staff who are working with people who are addicted, you've got a young person living in your treatment program maybe for months, and you get to know them and like them and see them do well and have them leave and feel confident that they're going to do well. And then 2 weeks after they were discharged, you find out that they died of an overdose. When that happens to staff enough, it makes them say, maybe we do need to do something differently. I think to some extent, the ideological barriers have been overplayed a bit. So you have many abstinence-based treatment programs that will tell you, we don't do buprenorphine here, we don't believe in it. I think that they're doing that because of some of these other barriers. I'm just going to stop in one minute. So I think they're doing it because of some of these other barriers. It's not, they're using ideology as an excuse. It's difficult for them to figure out how to do this. Doctors are expensive. If you're a drug treatment program, you generally want a physician for the least amount of time possible, because they're your most expensive employee. We have all of these caps on the number of patients a doctor can treat. We don't let NPs or PAs prescribe, even in states where they are allowed to prescribe Schedule IIIs. And we have done a lousy job of integrating addiction treatment into primary care. And primary care docs, especially the primary care docs who hate treating chronic pain with opioids, and with good reason, they think, well, why would I want to do addiction treatment with buprenorphine? I hate working with these patients. Primary care docs who actually give it a shot generally do find it rewarding to treat opioid addiction with buprenorphine. We've got these prior authorization requirements as well that are a barrier. And I will stop here. Thank you.